Abscesses. It's a very interesting topic. The reason I say it's a very interesting topic because most commonly when you encounter an abscess in your clinical practice, the first thing that you would think is incision and drainage is the answer. I've been teaching at board aspirants for quite some time, and when I'm teaching international dentist or anyone, even for the national boards, or I'm teaching a subject, the answer you'll find in every book is incision and drainage. So you're not wrong to think that the answer is incision and drainage. But this leads to the question, if for every abscess the answer is incision and drainage, do I have to know what kind of an abscess it is? What is the reason of the abscess? Well, yes, you should know what is the abscess, what is the reason of the abscess, because your treatment just not limit itself just to incision and drainage, but goes beyond it. And I'll tell you the reason why in this video. If you do not know me, I'm Dr. Swati Gupta. I am a DMD general dentist. I specialize in periodontology from India, and I make YouTube videos about clinical education, clinical dentistry, and healthcare. Let's get started. So abscesses, what I'm going to cover in this video is different type of abscesses and the treatment for those abscesses. Again, this is a clinical educational video, so I'm not going to be dwelling into how that abscess happens, but I'll give you some idea so that when you talk with your patients, you can answer. You can tell them. Most often, my patients ask me, how did I get this abscess? How did I get this abscess? Because that way, you can tell them why the treatment is something more. The treatment is just not restricted to doing an incision. Okay, so I hope with this video you get an idea of the different abscesses, how you diagnose them, and also what are the further treatments associated for the treatment of those abscesses. So first one that I'm going to be discussing here is gingival abscess. A gingival abscess is very common abscess. You'll see it all the time. The location, how do you identify? The first point of identification or distinction between different abscesses is their location. A location of an abscess can tell you a lot about the reason why it happened and then how would you treat it. So gingival abscess, if we can say, and let me have my pointer here for you. A gingival abscess, the location is very much restricted to the marginal gingiva or the interdental papilla area. Okay, it does not extend beyond. So if this is the mucogingival junction, it does not extend to your attached gingiva or the mucogingival junction. It will be just in marginal gingiva or interdental papillary region. And I'm going to change the highlighter here. So once you've understood it's a gingival abscess, yes, now it's important to understand how did it happen, and that's why you have to ask a patient also. So toothbrush bristle, a piece of apple core, any fragment, basically any foreign body when gets embedded into the gingiva can cause a gingival abscess. Now I had a patient I think months back who came with a huge gingival abscess in the lower anterior region. And I asked that patient, okay, did you eat something? Did you bite into something? And he said, no, I was just like, when did it start happening? So when I asked him when it started happening, he said, I don't remember, but I was, chewing on like mango, the seed, and I was having mango basically. And after that, 2 days later or one day later, something, I noticed this thing started happening and it's really hurting me. And you know what I found? So the treatment of a gingival abscess. So once I tell you the gingival abscess treatment, you'll understand what I did. So the treatment for this would be it ruptures spontaneously once the object is removed. So any foreign body that was there, once that foreign body is removed, the abscess on its own ruptures. So you know what I did? I just started, you took my curate and then I started cleaning that area. Okay, sub-G instrumentation, started cleaning that area. And there was so many threads, mango, so many threads of the fruit that was stuck in his anterior, in the interdental region. It was annoying, right? It was discomforting to him. And probably what happened is when he ate it, he was not able to remove it, or he did not remove it, or whatever he did, it got stuck, foreign body, the body reacted to it. and that he came up with the abscess. So usually gingival abscess is not necessarily they will have pus also. Sometimes they will just inflame, and although the name is abscess, so there would be pus, but it's not very traditional abscess where you will encounter a lot of pus in that region. Radiographically also, not necessarily you know probably that acute abscesses or any acute thing does not show up in a radiograph, because you need to have a certain amount of bone destruction happening to be seen on a radiograph. So this will not even show on a radiograph. Once you remove the foreign object, once you know that okay, an apple got stuck there, or you ask the history, you ask the patient, did you bite on something, did you eat something, did that start hurting after that, and then you remove that particular object, it will rupture. Second thing you can do is tell a patient to do some warm saline mouth rinses. Why warm saline mouth rinses? Because just to saline also works as maintaining the pH in that area. So the abscess, it's acidic environment. Saline is going to create an alkaline environment. It will help in the draining of the abscess further, making sure the healing starts happening. Now, do you need to give antibiotics or anti-inflammatory? And this is, I feel, really important to know. Why? Because the moment you tell your patient, or the patient comes with the swelling, they will ask you, I need antibiotics. But do you really need to give antibiotics? No. For a gingival abscess, the reason of that abscess was a foreign body got stuck into your gingival area that caused some proliferation, it caused infection. It's not necessarily infection also, it's basically the body responding to your foreign object, and it does not necessarily needs an antibiotic unless it is so bad. Again, it comes down to the clinical judgment. Unless that gingival abscess is really bad, maybe the patient hygiene is really bad, and everywhere you can see a lot of plaque and calculus, and they've not been brushing really well, and then on top of that an abscess has happened, and you think that even after I've removed the foreign object, the abscess, it's an open area, maybe it cause infection, then give an antibiotic. But otherwise, if you have a patient who has a very clean mouth, and just the reason, like my patient who had mango and the threads were stuck in his teeth, I did not have to give an antibiotic. I curated the area, cleaned it with my monojet syringe, debrided that area, irrigated it, put the patient on warm saline mouth rinses. That's it. And then you call your patient after a week and check on them. So gingival abscess is very easy. And now I think you are understanding why I lay stress on knowing what abscess it is, because your treatment varies accordingly. You don't need to give antibiotics in this case. You don't need to worry about radiographs because you know what it is. Okay. Second one, periodontal abscess. Now, periodontal abscess is, again, how will you differentiate it's a periodontal abscess? One thing to understand, if something is periodontal, there has to be a periodontal pocket. Okay, periodontal means the particular whatever is happening has gone to your supporting tissues. It is just not limited to your marginal gingiva, but it is restricted. It is spread everywhere. So if I'm looking here, if you see the extent of the patient's abscess, it is really spread everywhere. This is your mucogingival junction, right? This is your whole attached gingiva. Everything is involved. So here the abscess is in the supporting tissues, causing destruction of the bone, of the PDL, and it's lateral to a periodontal pocket. Okay. Now, symptoms. What will the patient come with? Other than having a very visible abscess, patient will obviously complain of throbbing pain, and patient will also complain, I've been trying to eat and it really hurts a lot. In severe cases, also what you would see is associated mobility. And what do I mean by severe cases? Periodontal abscess usually would occur, obviously, like we said, a periodontal pocket has to be there. It's chronic periodontitis. It could be acute periodontitis, but in acute periodontitis, you can make out from the abscess. Like sometimes the abscess is really firm, like stone hard firm, or it could be very, easily you can touch it and it's very soft. That kind of an abscess. So you can make out. And also from the patient's hygiene, you can make out that if it is associated with periodontitis, or if it is something chronic periodontitis, or if it is related to the calculus. So periodontal abscess has a lot of reasons. Again, like I said, I'm not going to go into the theory part of it. You can read about it. It could be when you have SRPs. Sometimes a patient comes back and they say, oh, I got an abscess because maybe when you were removing the subgcalculus, and that is often seen also when you're removing the subgcalculus but you do not irrigate, then sometimes the calculus gets stuck in deeper in the tissue, and that actually initiates a post response and periodontal abscess happens. So again, lateral to periodontal pocket, you had the abscess. um, like I said, many reasons, plaque and periodontitis. So periodontal abscess in supporting tissues, and obviously it's very visible. You can understand again from the location. It's not in the marginal gingiva, it's in the periodontal tissues, and the patient will have pain on biting, mobility in severe cases. How do you confirm this? Obviously, history of periodontitis, like that I've been saying. Presence of a periodontal pocket. It's periodontitis. Whenever there is a periodontal issue, please remember there has to be a periodontal pocket. Now, teeth is usually vital. Now, why it's important to understand it's vital, non-vital, because it will help you differentiate with periapical abscess also. The location, because of periapical as well as a periodontal abscess, are almost similar. But again, few things are going to distinct them, and that would be one thing: the tooth is vital. In a periodontal abscess, your tooth is vital. Radiographically, yes, there will be evidence of bone loss. If a pocket is happening, if there is a periodontal pocket, if there is a periodontitis case, and an abscess has happened, an abscess is a something signifying something larger in this case, in a periodontitis, and that will be visible radiographically. Like in this case, you can see this is the furcation area, and you can see this complete radiolucency, as well as you can obviously see um, the loss of the thickening of the PDL space around here, and you can see the bone loss that is progressing. And this is a very classical representation of a periodontal abscess. No, it doesn't have to be in your furcation area, it can be in any area, but it's a combined factors that will make you come to a diagnosis that it's a periodontal abscess. So again, to understand a periodontal abscess or to diagnose a periodontal abscess, the location is really important. You have to check if the tooth is vital. You have to see the presence of periodontal pocket. Okay, and then now here we come to your treatment. Yes, the first answer everyone thinks is establish drainage. How do you establish drainage in this? For if it's very minor, if it's a small abscess, then you can establish drainage through the pocket, through subgingival instrumentation. But this would be mostly if it's a small abscess. If it's a very large abscess, if it's an abscess that you think your lymph nodes are palpable, you will do your further check also. You will examine, so you can palpate for lymph nodes and everything. If you think that patient has started having some systemic symptoms there, and the abscess will not just drain by through the pocket, then you can make a tiny incision also. Now for that purpose, do it only if you are trained. Don't really take the risk that is a simple incision I have to do over the abscess and will start draining out. You have to be trained, or you should have uh, seen someone doing it, learned it from how to do an incision and drainage. It's not as simple as it sounds. But yes, if you want to drain it through the pocket, again, you should have seen someone doing it. You should have practiced it as a general dentist. If you've not really practiced, seen it, shadowed anyone doing it, you have no idea how to do it, then maybe a little bit of it with your curates, you can do sub-G instrumentation, but then refer to a periodontist so that they can be taken care of. And incision and drainage, like I said, might be necessary in certain cases. Again, if they're large abscesses, follow up after 2 weeks and refer to the periodontist. Now, why am I saying you should be referring to a periodontist? Because uh, it's a bone loss. It's a case of a classical bone loss. Periodontal pocket, there's a periodontal pocket happening. There is a bone loss has happened. Your furcation would be involved. So what needs to be done? The abscess happened because there was infection going on. There's a periodontal infection going on. With you just draining the abscess, even if you are trained to do the abscess drainage and you did the sub-GV instrumentation, after 2 weeks a patient comes back, you prescribe them antibiotics, and the patient comes back to you and their abscess is gone. That's not the end of the story here. because you have the cause of the abscess was something very different. The cause of the abscess was patient has a localized or it could be generalized periodontal infection that needs to be treated. If you are not trained as a general dentist, there are so many general dentists who know how to do perio surgeries, surgeries, identify and have the proper treatment plan. If you are not one of them, then just refer them to a periodontist. Do not stop at the stage of incision and drainage, and that's the end of the story, and you do not have to see them again. No, you have to follow up. You have to plan osteosurgery for them. If there is bone loss, then you have to plan the bone grafting, GTM membrane, or whatever is needed to correct whatever is going wrong in the patient's health in that area. Okay, so either you refer them to a periodontist so they can further do the osteosurgery or plan whatever needs to be done, or you, if you're trained enough, then you do it. But periodontal abscesses, the treatment does not just end with incision and drainage. Let's go to our third abscess, periapical abscess. Now again, like I said, a periapical abscess location could be very similar to your periodontal abscess. So it could be the same location, location is mostly at the apex of the root, but clinically again, you have to differentiate it from your periodontal abscess, okay? Because again, the locations are almost similar. Now, symptoms. Symptoms are almost the same. I have throbbing pain, I have pain radiating to my ear, neck, and the jaw. Also, on the tooth, I have sensitivity to hot and cold. Very similar symptoms. The symptoms are not going to help you understand which abscess it is. Sometimes, even the location is not going to really help you. It's not necessarily that the abscess will be at the apex of the root. Like we say, for periodontal, is lateral to the periodontal pocket. For periapical abscess, not necessarily doesn't have to be. The location could be very different. So how do you diagnose? Mostly the tooth is non-vital. Okay, so mostly a periapical abscess, the infection has gone to the apex. So let's imagine if this was the root of this abscess. So we know that the infection has already gone till the abscess, and there is a periapical abscess happening here, and this is what you are seeing clinically. But yes, the infection has somehow gone deeper. There's a periapical, I mean, the tooth might be carious also. So tooth could be carious, there could be a large deep restoration, and the tooth is non-vital at this point, and there is a periapical abscess. It obviously, like I said, extensive carious tooth, a draining apical abscess. Okay, so it could be draining, like you have, I'll show you in a picture. And radiographically, you will have an apical rarefaction, which actually suggests a periapical abscess. But again, like I told you, acute abscesses will not have any radiographic signs. So sometimes, even if it's a periapical abscess, usually periapical abscesses will develop because of the chronic infection that is happening, like extensively carious tooth, broken tooth, damaged tooth, and that would be seen on a radiograph. But if you do not see, or there is a very tiny hint of an abscess, do not be surprised. Okay, so this is the example of what I was saying, a drainical abscess. So if what you see, this has actually become a fistula at this point, like the abscess that's drained, and this is just a fistula. So this is the tooth, this is your tooth, right? And somewhere deeper are the apex, and this is a draining fistula at this point. So you can not necessarily will have a draining abscess. Maybe the patient comes with a fistula. And then apically, like we always see, usually apical abscesses are easier to diagnose. Like you can see here, a very prominent apical rarefaction. So these are usually at the apex. Like see in this scenario, you have something happening here, and at the same time you have it around both the roots. Both the roots have something happening here. So this particular case could be a case of an endoperiolesion lesion. And what happens in an endoperiolesion lesion? You can have a periodontal pocket. Okay, here it does not really seem like there's a bone loss, extensive bone loss or anything happening. But what could have happened is, through the presence of lateral canals, you can have this route happening. The infection is spreading from your apical region to your furcation region, or the other way. But it's a very classical example of an endoperiolesion lesion also, where you will see abscess in the furcation region and abscess in your apical region. And if the tooth is vital, if there's a periodontitis happening, and then you see something like this, right, and there is a periodontal pocket, then it's basically a periodontal infection that might have caused an apical infection. But if there is an extensively carious tooth and you see something like this, then the chances are, and there is no pocket but the tooth is just non-vital, then the chances are it has gone from your apex till your supporting tissues of the tooth. So this particular example is a very classical endoperio, whereas this one is a very classical periapical abscess that you would see. So again, how would you treat a periapical abscess? You will start the patient on antibiotics, right? If you are again trained to drain it somehow, like in this, maybe if you're trained to drain, you can make a tiny incision line, or you can, if you're and you can drain the abscess. It doesn't really have to be like they say that it has to be at the most fluctuant point of the abscess. So if there is a draining abscess, then you will see a tiny fistule, a tiny pustule here, and then all you have to do is just you can try to drain it. But again, if you've not been trained how to do it, if you have no idea how to do it, don't even try to do it. Just refer it to the endodontist. Okay. And start the patient on antibiotics for sure, because there's a periapical infection in this case, and refer to the endodontist regardless. Even if you know how to drain it a bit and it's already the patient comes to you with a draining abscess, like with a pustule here, then you follow up the patient after 2 weeks or after a week after starting the patient on antibiotics, assess the area, how well it's draining, refer to the endodontist. What would the endodontist do? Either they do it RCT, or maybe sometimes it's a draining abscess and the apex is really infected, so that would become a surgical procedure like an epico. Okay, so again, based on your understanding of the abscess, your treatment was not just limited to incision and drainage, it went beyond that. It went beyond to deciding how to treat the source of the infection, not just treating symptomatically what I saw. And something that is happening, something as a general dentist, maybe you're not really trained how to deal with, are peri-implant abscesses. Now, peri-implant abscesses or apical peri-implantitis, with the whole prominence of implants, everyone is placing implants. If you've placed implant in an infected site, there are lots of reasons to get a peri-implant infection, a peri-implant abscess. The reason I'm discussing this is so that you have an idea that if something like that you see, you should not be like, what is it? I have no idea. So these are peri-implant infections, retrograde peri-implantitis, lots of things. There is a lots of studies have come out, decision making, clinical making, implant surgery or implant extraction. But again, that is not something you would do as a general dentist. You would refer to a periodontist, or you would refer to an oral surgeon and have them make the call of how they want to go about with that particular peri-implant infection they see. So by now, I'm pretty sure that you have an idea of what I was trying to say when I started the video, right? That diagnosis is really important. And with all my videos, you will understand that I'm always playing a lot of stress on diagnosis. If you do not diagnose the problem, you do not know how to treat. And if you want to be big amongst your patients, if you want them to remember you, they should remember you by the fact that you did a good diagnosis, because diagnosis leads to correct treatment plans. And if you do not know how to make a correct diagnosis, then you would send it to a specialist or someone who can make a diagnosis based on just because they've done specialization in that particular topic. So I'm going to leave you with one question now. The question is, can you identify this marked tissue, this inflammation, this enlargement that is here? I would love to know your comments, and I would love to know if you know the answer of what is this. I'm going to leave you here, and I'll see you in the next video.